webinar. Vi ricordo che il titolo del webinar è l'European Health Data Space, il potenziale dello scambio di dati sanitari. Abbiamo il piacere di avere con noi come relatore principale Licinio Custramano della DG for Health and Food Safety. Di fatto il dottor Custramano ci presenterà l'iniziativa della Commissione europea per la creazione di uno spazio europeo dei dati con un focus proprio specifico sul settore sanitario. Questa iniziativa diciamo che ha un periodo di attività che va dal 2019, quindi è già iniziata e vedrà la sua conclusione comunque con il raggiungimento degli obiettivi nell'anno del 2025. E quello che oggi vorremmo capire con il nostro relatore è innanzitutto le caratteristiche di questa iniziativa che probabilmente non è a tutti nota, anche se giustamente e anche fortemente promossa dalla Commissione europea. E le potenzialità di questo spazio, nel senso che vorremmo anche capire, glielo abbiamo proprio chiesto, di capire che tipo di collaborazione può esserci anche dall'Italia e dalle regioni in particolare, visto che insomma, come sapete, il Programma internazionale di salute è una rete che coinvolge tutte le regioni italiane, oltre che ovviamente il Ministero della Salute. Per quanto ci riguarda, l'interesse è molto forte, da una parte per la tematica e quindi il tema della digitalizzazione e quindi il tema della necessità dell'interoperabilità che è molto forte anche a livello nazionale, quindi ci immaginiamo che sia ancora più necessaria tra diversi stati membri e tra diverse regioni confinanti. E di fatto il nuovo programma per la salute, il programma di finanziamento, la nuova programmazione EU4Health ha tra i suoi obiettivi proprio l'affrontare le minacce transfrontaliere in modo più efficace. Questo significa che vi è la forte necessità di avere una forte cooperazione tra paesi, tra regioni confinanti e questo lo si può fare proprio collegandoci, anche potendo condividere dati e informazioni importanti su pazienti, cittadini, ma anche insomma, proprio tra servizi sanitari. Voi sapete, l'abbiamo detto in qualche nostro webinar, che il Promise, affiancando il Ministero della Salute, parteciperà alla joint action che si avvierà a brevissimo, proprio finanziata da DG Sante, sulla implementazione del programma EU4Health e in particolare il Promise ha proprio la leadership di due pacchetti di lavoro, l'uno sulla sostenibilità del programma, l'altro sulla capacity building dei national focal point di questo programma specifico. E questo stesso programma andrà a finanziare anche in parte azioni rispetto a questo spazio di interoperabilità tra i sistemi sanitari e quindi insomma ci impegneremo a collegarci sempre di più con questa iniziativa perché il nostro ruolo non sarà solo quello di portare a livello nazionale le opportunità di finanziamento che dà e darà questo programma, ma anche proprio per portare a livello nazionale, trarre beneficio da iniziative che di fatto saranno attivate a livello europeo e quindi in qualche modo collegata a questa tematica, in qualche modo insomma tutte le regioni possano beneficiarne. E io di fatto mi fermo qua, anche perché ho detto troppo, e lascio quindi la parola al nostro relatore principale, informandovi che a seguire alla relazione principale abbiamo coinvolto un po' di regioni, Lombardia, Friuli Venezia Giulia, Campania, Marche e Provincia Autonoma di Trento con la Fondazione FBK, per una sorta di dibattito sul tema, quindi non saranno delle relazioni da parte di queste regioni, ma di fatto saranno altre domande che probabilmente verranno rivolte al relatore in base a quello che ascolteremo, ma proprio in base al tipo di ruolo e al tipo di contributo che proprio le regioni stesse possono dare a questa iniziativa. Vi ricordo di spegnere i microfoni per chi non parla e che c'è l'app con la traduzione per chi deve seguire la presentazione in italiano. Lascio quindi la parola al dottor Custramano, ringraziandolo tantissimo della disponibilità e buon lavoro a tutti.
Good morning. I'm sorry, is this the right moment to start the presentation?
Yes, this is
Oh,
the right moment, yes.
because there was no translation. My Italian
Oh,
is
I'm sorry.
my Italian is is
I'm sorry.
short, but
I
it's
present your presentation and follow your presentation. Many regions collaborate in the discussion with question to your attention and so on. So please start your presentation. Thank you very much.
Thank you very much for the invite to be here today. It's a pleasure. And by pleasure, I have a hidden agenda, meaning that the European health data space at this point is an idea. It's something that the Commission aims, the member states aim, and every citizen or some citizens aim at have it in place, but it's still in a construct phase. So if there is a takeaway message is everything that you will see regarding the European health data space, in particular for secondary use of health data, are plans that you can contribute to. So that is one of the key takeaways. So moving to starting with a mission, it's always good to make us to that to the movies. The mission impossible, but I think this one is possible. The mission from Stella Kyriakidis, Commissioner for Health, where her mission is to work on the creation of a European health data space to promote health data exchange and support research on new preventive strategies, as well as on treatments, medicines, medical devices, and outcomes. So this goal, this aim of the European health data space, beyond being in everyone's mind, is in fact in the core of the mission of our Commissioner for Health. So this gives a lot of power, but it didn't start there. It started already so long ago. And one example where DG Santé and the Commission have been working, aligning with, is the 2018 communication on enabling the digital transformation of healthcare. As you can see here, the three pillars here: better access for citizens to their health data, connect and share health data for research, fast diagnosis, and better health outcomes, and use the digital services for citizen empowerment regarding healthcare services. So this is already for some time going, and much before 2018. These are just milestones that highlight the idea, the vision, where to get. From that vision that is already long, it's started becoming clear that regarding health data, there are mainly two type of use. So the primary use that we use this definition to say is using health data to treat the patient, the patient. So I use Licinio, the health data to treat Licinio, so healthcare purposes. So this is how generically we define primary use of health data. For secondary use of health data is the use of Licinio's data together with other citizens' data for policy making, meaning organizing how the healthcare system is working and the health policies that drive our society. Regulatory activities, for example, for medicines and health technology. So these actors also need access to the health data, not to treat the patient directly, but mainly to regulate before something gets to the market and to monitor the performance of something that is on the market. And last but not the least, to research and innovate, meaning the use of health data to create new treatments, new diagnosis techniques, innovation, bringing innovation to the health sector. So let's use this definition. You may fine-tune this definition, but for sake of the presentation, let's use this primary use for healthcare purpose, secondary use for policy making, regulatory activities, and research innovation. Thank you for coping with this. So regarding primary use of health data, and this is where we have been working for the last, let's say, more than 10 years, but today we already can. And I mean we as European citizens. I'm not entirely sure if you are familiar with My Health at EU. It was previously called eHealth Digital Service Infrastructure. My Health at EU is an infrastructure that enables any of us European citizens, when we are traveling for sake of work, tourism, or education, so when we are abroad, and if we need to go to a pharmacy or to a hospital, the health professional that will take care of us will have access to information coming from our home country. So Licinio goes to Italy to the conference of promise, and suddenly Licinio needs to go to the hospital, and the doctor at the hospital will be able to retrieve from Portugal the most important information, the essential information from Licinio. For example, if he has any allergies, current medication, problems that he has, the vaccines that he took, and some more information. And this will be provided to the doctor in a language in Italian. So semantic interoperability is very strong there. So this is one of the major efforts we have been doing. You may recognize the word national contact point. And this is, as you will see, this will be also the source of inspiration for something more in secondary use. So we are still in the world of primary use, and the national contact points for eHealth are organizations in each of our countries that are the entry points for communication with other countries, meaning any hospital in Italy, if that is taking care of Licinio, that hospital will have the capability to contact the national contact point that will contact home country from Licinio, that is Portugal, to retrieve the patient summary or the e-prescription if we are in a pharmacy. So how I start by saying that this is already what we can already do today. In fact, and to be precise, we can do today the dark greens. You see those countries in dark green? These are the ones that are connected. For 2021, we have the light greens, the countries that are joining us. And we see there also in the 2022 that Italy is expected to join to the My Health at EU, benefiting Italian citizens that go abroad or other citizens that go to Italy to work, for tourism, or to study. So this is a tremendous effort. If you'd like to know more about this, we can go really deep into the different levels of interoperability, legal, organizational, semantic, and technical. We can go there. I would like to move to another example, that is the European reference networks. This is already today available for, imagine when there are citizens, where there are patients that are affected by rare diseases or very low prevalence diseases, and the knowledge may be low in some regions of Italy or in Portugal, whatever country that patient is. And in order to overcome those geographical and number and knowledge gaps that may exist in a rare disease, the European reference networks provide the doctors treating those patients an ability to create a virtual panel with doctors and health professionals from other countries that may have expertise and knowledge in that rare disease. The combined knowledge of those doctors will help the home doctor that needs to take care of that rare disease with enough knowledge, or let's say added knowledge, additional knowledge, in order to do a better diagnosis and actually to design a better treatment for that patient. So this is also in the scope of primary use of health data and how these digital services are being used to increase or to extend the power of health services. So now, stepping forward to secondary use of health data, and this is for tomorrow. I know that many of you will say, Licinio, but there is already so many things going on. Exactly. And those so many things resulted in very concrete wins. So we have achieved a lot, but we also created what we will see as fragmentation. So let's dive into the challenges of secondary use of health data, not focusing yet on health data, but cross-sector. So Europe launched a strategy for data. So Europe assumes, the European Union assumes that data is the energy that will drive the innovation that we need in our market. So data can flow within the European Union as people flow and across sectors. This is something extraordinary across sectors, and in healthcare, we know that many of the studies would need to involve different type of elements like environment, professional elements. So if you want to make a study, you may need to combine information from different sectors. This is extremely relevant. Availability of high quality data to create and innovate. I believe that if there is something where we all can agree on, is that the insights, the quality of insights you can take out of data is equal to the quality of data. So poor data will drive to poor insights. High quality data will most likely drive to high quality insights and conclusions. So how can we work towards that? European rules, values, fully respected. The question here is how to create this idea of market, but societal values and ethical values to respect that the individual and the freedoms of the individual. And not last but not the least, rules to access and use data are fair, practical, clear, and a clear governance mechanism are in place. Who established the rules? If we citizens need to complain, to whom we need to complain, and which are our rights. So this is in overall the strategy, but that is trying to address some of the most common problems that you probably faced at country level. Not enough data available for reuse, meaning I think all of us have heard someone saying, I want to make this study, but this data is not available. Or I need data from all the country or from other countries, and this data is not available. So how can we overcome this not enough availability of data? Lack of European data processing and storage solutions. Some of you may say, oh, there is now so many cloud solutions that would allow us to have any power to process data. Is that so? Is that type of cloud storage and processing capabilities fine-tuned for health data, rules, values? Or should we need to work more a little bit on that? Access on comprehensive data governance and approaches. So we already talk a little bit on how, to whom can we complain, who has that role and responsibility to govern how data is used. But we also should look at who should define the interoperability, the standardization and harmonization efforts, who can drive. We should also not forget that we are investing a lot in buying equipment and buying servers and software, but there is the human is still the most important element in the whole value chain. If the humans, professionals and patients and citizens are not skilled to deal with this new reality, these new technologies available, that will not be enough. That will just be short. And then obviously, there is no real empowerment of the user in terms of the user is still a passive element in regarding the secondary use of his data. He can say, yes, I consent, or he can say something more. He can be informed, but there is no real empowerment, no real understanding on how data is being used and what has been successfully outcome from that use. So there are common problems, and it's important to recognize the problems, but it's also important to build pillars through which solutions can be made. And we have this idea that a cross-sectorial governance framework is needed. So if we want to make sure that data, when necessary and when desired, data is available across cross-sector, there should be already a governance framework that is bringing together the different sectors and creating common rules so that they can work together. Enablers, about most of the enablers are about funding. I got some questions about funding. The EU, I can provide you some answers on how the EU for Health, how the Recovery and Resilience Facility funding mechanisms can support. There is a lot of support in terms of investment. We need to be ready, and the countries need to be ready to apply for it. Competences, we spoke about empowering the individuals, about digital skills, and data literacy is not just about skills, it's also about literacy. And rollout, making these common data spaces, so sectorial data spaces, a reality. So they need to exist and be materialized in some sort, not just on one element, legal. It needs to go for the different layers of legal, organizational, semantic, and technical. To have an idea, what are we talking about when we say sectors? We can go from health, industrial and manufacture, agriculture, finance, mobility, Green Deal, energy, public administration, and skills. I think it's a common understanding that for health purposes, for health studies, there are so different information that can come from different elements, from agriculture, from skills, public administration, energy, so that you can combine, to example, to determine, to learn more on which are the things that are causing specific diseases on people. It's the agriculture, it's about the environment, what is there. So in order to make this work together, we need more than just a common governance around this. We need to have these technical tools for data pooling and sharing, standards and interoperability. If data will flow between sectors, there needs to be some clear framework on the standards used to define the meaning of the information and the technical means for information to flow from sector to sector. And then this IT capacity, the cloud storage and processing services, it's important to understand how these work for different spaces, but at the same time addresses specific sectors' requirements, like the healthcare, where data is highly sensitive. So having that specificities of the health sector, DG Santé has been working hard to create channels where we can learn, like today we will learn from you, channels where we can learn how this European health data space should look like and how it can be built in order to address and preserve the diversity, but at the same time create harmonization in the different domains inside health. So we found some problems. These are the very common problems that you face. Access to health data for healthcare in cross-border context. We focus we start with cross-border issues because that's where our mandate is more strong from the European Union. So patients cannot access and share their health data cross-border. We have seen the eHealth ESI, but you have seen also that there is limited deployment. There are more countries in the coming years to join than the ones that joined so far. So there are some challenges there. And limited digital interoperability of the healthcare providers. At this point, it's not clear that a Portuguese and an Italian healthcare providers can connect to each other and work together. So there are limitations at that side. We also identified as problem access to health data for secondary purposes. So the first one is about providing health services for secondary purpose. So low reuse of health data for research and policy making, and even lower when we say cross-country data reuse for policy making. That's very difficult. Of course, you may say, oh, we have ECDC that is responsible for doing this European-wide. Indeed, but do you have the tools as an Italian authority to get data for other countries and establish policies inside your country? Possibly you could have when the European health data space will be available. Cross-border access to health data for secondary purposes is unclear and cumbersome. What we mean by that is we have this tremendous asset in Europe that is the General Data Protection Regulation. But this regulation is cross-sectorial, so it creates rules, very clear rules, but then it opens the door for specificity and that each country can have in terms on how it is materialized for specific type of data. And that specificity is very different in different countries. That leads us to somehow unclear on specific aspects as secondary use of health data for policymaking, research, and regulatory activities. It also leads us to this fragmented infrastructure for data use in research and policymaking. And by fragmented, we have learned so much in the last 2 years about research infrastructures for specific domains, for cancer, for biobanks, for genomic, for rare diseases. There are so many out there, and they are doing a tremendous, important, valuable work. But they are doing it in isolation, and their value is limited to what they can do with the data that they have, because all of them identify as a limiting factor the fact that they don't have access to a broader range of health data. And that's the fragmented infrastructure. And at the same point, we also acknowledge that the eHealth network has been working heavily on the primary use of health data, like the myhealth.eu, but has not been so strong regarding secondary use of health data. So there's limitations there. We also acknowledge that there are problems regarding the limited free movement of digital health services like telehealth, mHealth. And we spoke already a little bit about the uneven legislative framework. The quality framework is totally absent. There is no common quality framework regarding what it means quality in terms of telehealth and health data. There is no such thing regarding healthcare service, or let me rephrase, we are not aware at this point of such frameworks, and we believe that this should be addressed. And and the procedures for prescription, reimbursement, and also liability are not equal across member states, and this limits the use of telehealth services from a citizen that is in Portugal and then is consuming services, telehealth services, or mHealth services from a provider in Italy, and vice versa. And last but not the least, the promising AI, artificial intelligence in healthcare. There are a lot of gaps on how the artificial intelligence can deliver its promise to the services. There are ideas, there are beacons of examples on how that can be done. But there are so many questions, and one in particular is the liability of the introduction of artificial intelligence in previously mainly human-driven processes in healthcare. So AI liability is one of the concerns we have already identified at this point. So we know that one of the principles is to respect the rules of our society and the rules of the European Union, and we are a union of law. And that's the starting point. We have these good points: the General Data Protection Regulation, we have the Data Governance Act, and we have the Artificial Intelligence Framework. We invite everyone to look to those. Are those sufficient for an European health data space? We believe there are sufficient specificities in the health sector that would require further regulation or additional elements in the regulatory framework. Use of health for healthcare purposes. How can we facilitate citizens to have control over their health data and make that data available to any healthcare provider that they will request to be taken care or treated? Use of data for research, policy making, and regulatory decisions. Health data is sensitive by default, meaning that how to create these legal grounds for this data to be widely available for these purposes, policymaking, regulatory, and research, at the same time that it's protecting the individual, the privacy of the individual, and it's not used against the individual. Provision of telehealth and mHealth, including cross-border. So these services that all we hear, and that the COVID-19 shown that how telehealth is extremely important in order to overcome the limitations of not being able to move to a specific healthcare place. Can this be seen from a cross-border perspective? is there the use cases where, from a cross-border perspective, telehealth and ham health are relevant to be addressed and protected and foreseen in the regulatory framework? And also the use of AI in health, clarify aspects like liability and how that should be addressed from a regulatory point of view. So this is what we are trying to aim to address some of these problems in the European health data space regulation. In terms of unifying primary and secondary use of health data, we created this framework that you see in front of you that tries to distinguish but bring things together. So horizontally, you see that better healthcare, and when we say better healthcare, we ask ourselves, what can we do from a legal governance point of view, quality of data, infrastructure, and capacity building point of view? What can we do to support better healthcare? So the primary use of health data. And we make that question and we try to ask, is there something from the legal governance point of view that we should do? Is there something from the quality of data frameworks, semantic interoperability that we could do? From the infrastructure, there's something that we can launch that help and enables better healthcare and capacity building. So is there something that we can support nationally and European-wide programs to train and enhance cross-border cooperation? So that's the better healthcare. The next two horizontally is the better policy making and better research and innovation. So as you can see, we are trying to focus, our starting point is the legislative and non-legislative measures, like the renewal of the Patients' Right Directive, Article 14, that established the health network, but goes much beyond that. Rules for access to health data, interoperability, and citizens' right. So we are asking ourselves, how far can we go to establish the necessary legal and governance means for things to unfold in our countries? From a quality point of data, we have been working heavily in electronic health record formats. We have been working with the eHealth network in doing that, and we have been working with other stakeholders. Possibly you are familiar with the European Electronic Health Record Exchange format that takes the best of the guidelines from the health network for e-prescription, for patient summary, and tries to create the path for laboratory results, imaging reports and results, and as well as discharge letters. So it tries to move that information forward. And why is that so important? Because secondary use can only be done based on that principle. If the quality of data is good when you capture it for healthcare, it will also be meaningful and good for what comes after, that is the secondary use of health data. And for that, we have identified the need of verification projects. What are those verification projects? You possibly are familiar with the term FAIR, findable, accessible, interoperable, and reusable health data. So we know that data is captured around Europe in different forms and formats. When there is the need to exchange data, the organizations try to agree on the interoperability standards that they will use. But that's not always the case. And what we are wondering and questioning ourselves is there any way we could support projects that say, I want to make my hospital data available according to a European interoperability framework, and I want to apply to make my data fair. So findable, accessible, interoperable, and reuse. Those would be verification projects. And other mechanisms for data quality, like labeling the quality of data that is in a certain hospital, and how that label can increase the value of that data, and you can be requested for data more often, but you can also apply for fundings to keep that label on data quality. On infrastructure, you have seen some examples on where we have been invested for healthcare. So the My Healthy at EU is the perfect example where we have been investing, and the Union expects to continue to invest in member states as well to achieve a full coverage of the European Union and possibly go beyond the patient summary, e-prescription, and actually add there the possibility of laboratory results exchange, image reports and results exchange, and discharge letters. My Health, that's mainly for better healthcare. But then it's this need, we found that the secondary use of data brings together different actors. So research infrastructure, data authorization bodies, registries. These actors are not directly involved in the primary use of data. And for that, they are not in the scope of My Health at You that has been built specifically to deliver better healthcare. So the question is, how can we address, how can we extend, how can we support this EU-wide infrastructure for secondary use? We'll give you an idea on that and what we are doing on that. And then capacity building. I think this is the commonly agreed that we need to invest in people. We need to capacitate people to train, to build knowledge, but also to increase the literacy of our citizens, meaning to make them comfortable and taking the advantage of the technology, not to be victims, but to be empowered. And that's what we believe we need to work with the member states to build these programs to train professionals and to empower citizens. In terms of how have we started addressing, I think I have 10 more minutes for my presentation and then I will be over, and I really would like to hear more questions from you. So what are we doing to build this European health data space idea, plan, what it will be, the vision for it? So we have been running several studies, and 4 of them are here on the slide. The first one, assessing the rules on how health data is being processed in the light of GDPR. And this is published, there is the link here, and this one is the one that allows us to understand that in the light of GDPR, it's different in many countries. So there are differences. And for that, the question is, how can we harmonize and create a common baseline? So the second study that we are running, and we have workshops with stakeholders, and our plan is to be finalized by June, is about regulatory gaps. So where in each country you identify obstacles or drivers that impede the processing of health data. Then regarding infrastructure study, we are starting it now, and this will look to options on what type of infrastructures, how they should be governed, how they should be deployed, and how they should look like, so that these infrastructures will endure in time, like the other type of infrastructures that we have in our country that are considered critical infrastructures. And then the impact assessment study, this is the most important one. This is the one that will assess the impact of a potential regulation in the field of the European health data space. So this is to be started in May, and this will be an 18-week long. So in all these studies, you have something to say, you have a say. You can participate in stakeholders consultation and interviews, and that's the purpose of these studies, is to learn, to hear what is out there, problems, solutions, and try to bring them as input to the impact assessment study. One of the other ways to try to learn is, of course, we can do studies, but we can also run pilots. And in fact, there is this idea, let's try to simulate how an EU-wide infrastructure would look like and try technology, interoperability agreements, semantic agreements, organizational agreements, and the underlying IT infrastructure to demonstrate if this exists, this would be powerful, but this would be, but these are the constraints, these are the building blocks for such infrastructure to exist. So there are a couple of questions that we try to address that I've been already highlighting with this pilot. And by the way, when we say EHDS2, meaning the 2 means secondary use of data, pilot means a pilot to try to see what an infrastructure will look like for that. And in this pilot, we are trying to understand which are the minimum, because we always speak about the minimum, not the maximum, the minimum legal governance arrangements to make large-scale cross-border reuse of health data possible, the minimum IT infrastructure to make it possible, the minimum health data requirements, which are the economic models that are needed in order to establish this sustainable ecosystem to keep the balance. And what type of research questions can be done through this principle of federated query and data analysis? We can go deeper on this if anyone would like to. Why are we looking very sharply to this federated querying and data analysis? And last but not the least, which are the investment needs? Where is the support, financial support needs to make this vision, to make these answers to these questions large scale and available in all countries of Europe, in all member states? Just a small diagram, because the ones that know me know that there needs to always be a diagram in terms of infrastructure. So the pilot concept is very simple. Imagine the idea that there are nodes, and nodes are entry points for the European health data space, are doors to the European health data space. What does it mean? It means that nodes speak the same language, the same standards, the same rules, and they obey to the same policies and to the same laws. So the nodes are very like to each other. They are exactly the same. It's a level playing field. Behind each node, there is a jurisdiction, and that jurisdiction can be a country, a member state, it can be a region, so it can be different things. But what we know, the pattern is that there are two types of main actors: the ones that have data, health data, data holders, and the ones that are that have need to consume data for research, policy making, and regulation. So let's give one step further in this diagram. It looks like a little bit more complicated, but let's go to the down right side. So we have there the different type of nodes. The first type of nodes, and this was one of the questions we got, is the first type of node that we foresee is the existence of this idea of an authority that is a member state permit authority. And that authority is the entry point for incoming requests from all around Europe. So they are the ones that we believe could be in the position to accept or refuse some of these requests and so forth. So this data permit authority will be affiliating data holders, for example, hospitals, registries, healthcare providers that have data and want to make this data available for secondary purposes. And the data consumers are the three actors that we have identified, are the ones that have. So imagine if someone in Italy, in a public health authority, would like to know more on what is happening in Malta in terms of data, health related with the health data, you could send a request through the National Permit Authority to the Maltese Permit Authority and bring back that information. Or you can send that request to all countries in Europe and build your own data cube where you can make the analysis and take conclusions for Italy what you want to do. But there are other type of nodes. So we start with the member state permit authorities that are representing this kind of entry point into a specific member state. But there are EU level agencies like EMA and ECDC that have tremendous need for information for regulatory purposes, for surveillance purposes. But for example, ECDC also has a huge amount of data that they are currently already making it available through the websites, but that information could also be available for anyone that would like to use that information, and you could use the European Health Data Space for that. Two types of nodes more that we have identified as needs, possibly more exist, but research infrastructures. We know that there are so many looking to genomic, looking to biobanks, looking to rare diseases, looking to cancer. We know that there are research infrastructure that have established a huge network of partners that help them to build studies, cohorts for the studies. So in the European health data space, we say, let's keep the diversity. How you work already, it's okay. You can continue work on that. The challenge that you have, research infrastructure, is the following. Would you like to make that data available for a European health data space? If yes, deploy an European health data space node, meaning that you will use the same standards when you speak to others. Internally, you can use the standards you have already deployed, so its diversity is kept. But when you speak to others, you need to speak in the same language and vice versa. And last but not the least, the EU Permit Authority. What is this? Is the place for the orphans. Imagine that, let's start with what is an orphan consumer, someone that comes from outside EU, a researcher that would like to make a research question to the full EU. So if it comes from outside EU, it will not be under the supervision jurisdiction of a specific country. So he could address the European Permit Authority and say, I have this research question and I would like to make this research question. And the EU Permit Authority would authorize or not him to do that question and send that question to the other countries. Orphan data holders may be, for example, patient registries that have been established by multinational organizations that are non-for-profit. Most of these are patient-driven organizations, patient associations, and they have been established, but they are not under the jurisdiction of a specific country. So the question is, can the EU Permit Authority be the home for those data holders in terms of infrastructure and in terms of governance, in terms of permit to access data or not? That's a possibility. So this is somehow the baseline for the European health data space pilot for secondary use of health data and the nodes concept. Now you heard about the nodes, so you know the baseline, or let's say the baseline design we are starting with when we go for our conversations. So last slide in the map here is, so if regulation is the strongest, and at least let me say it like this, we are a union of law, and this is where we need to start. We can start from several places, as you see that we are working in several elements, but we need to start on that. So what is the concrete roadmap for the regulation? So we are now entering in the public consultation phase, meaning that there will be open to every citizen in Europe consultation on what the European health data space, and in particular this regulation, should protect and should aim at. Then there will be an impact assessment in Q3, so it's the second half of the year, on what would be the impact of such regulation. And it will include inputs from consultations, from studies, even from a joint action, that is joint action on European health data space. You may, if you want to know more on that, we can speak a little bit on that. A joint action that is trying to look for options that can be included also in the design of the European health data space. European Data Protection Supervisor will be consulted as well to make sure that the rules and on data privacy are protected in such a proposal, and expected, this is the ideal plan, the legal proposal would come out in Q4. I can tell you that there are some doubts if we will manage to do it in Q4 or early 2022. So this is the last slide. It's not very exciting in terms it's the legal proposal, but you know, this is the solid cornerstone for everything else to flourish. At least that's our belief. I would be super glad to take some questions, challenges, and even more glad if there are some suggestions during today's conversation. Thank you very much.
Thank you very much, Licinio. Very, very useful. We need, before to proceed with the next session, that you make the access to the app for the translation service. Please, Licinio, can you proceed?
I'm in the app.
We can make the session in Italian.
Yes.
The code is 6559.
I'm in.
Okay. You are connected with the translation service? Ok, thank you very much. Ok, grazie mille, torno a parlare in italiano che è anche più semplice per me e quindi insomma sono più agevolata. Allora, ti stavo ringraziando Licinio per l'assoluta chiarezza di esposizione rispetto anche a tutti i contenuti, in parte conosciuti almeno insomma da me, in parte anche un po' nuovi proprio relativamente alle nuove iniziative che sono già avviate o che state per avviare rispetto ai nuovi studi. E io avrei già un po' di domande, le faccio, te le elenco e poi passo la parola alle regioni e vediamo un po' insieme come gestire questa seconda sessione. Nel senso che le primissime vabbè, la prima è una considerazione rispetto agli studi che state avviando, che avete già avviato, e sicuramente torneremo a te per collegarci una volta che a mano arrivano gli esiti e per presentare alla nostra platea nazionale un po' i risultati, in modo che ci teniamo collegati all'iniziativa e riusciamo bene a dare un impatto forte a livello nazionale italiano. Questo è importante, proprio la conoscenza di tutto. E la seconda cosa che volevo chiedere in realtà è proprio quando dici che possiamo partecipare alle iniziative e agli studi, anche avere chiarezza su questo, cioè con quale modalità. Tu sai che noi rappresentiamo un po' le regioni, tutte le regioni italiane e province autonome e nella nostra cabina di regia c'è il Ministero della Salute. Noi sappiamo bene che lavorate in stretta collaborazione con il Ministero della Salute e anche probabilmente con qualche regione. Ci piacerebbe sapere come poterci collegare e coinvolgere un po', non dico tutte le regioni, ma insomma la maggior parte rispetto a queste iniziative. Quindi questa è un po' la prima cosa che ti chiedo. La seconda cosa è di sapere in che modo siete collegati con DigiConnect. Sicuramente siete collegati con DigiConnect, ma anche rispetto all'iniziativa del programma Digital Europe dell'Innovation Hub e quindi a tutto anche il lavoro di digitalizzazione che sta avvenendo nei vari Stati membri, anche accelerato dalla pandemia. Ecco, per darci anche un po' un orientamento rispetto a questo, perché noi cerchiamo sempre di creare anche sinergie tra settori e iniziative diverse, quindi ecco, questa era un po' l'altra cosa che volevo dirti. Ed infine, e poi mi taccio, solo informarti del fatto che noi abbiamo un tavolo di lavoro specifico sul tema del turismo sanitario, che in qualche modo chiaramente abbiamo affrontato il tema della direttiva cross border, da quella siamo partiti, parliamo di turismo sanitario, quindi non diciamo dell'emergenza del turista che viaggia. Ecco, e volevo lanciare un po' di iniziative su questo e penso che il tema del digitale e dell'interoperabilità possa anche essere un tema rispetto a lanciare iniziative innovative rispetto al tema del turismo sanitario. E non è vero che mi taccio perché manca solo una cosa. Sì, qualche informazione in più rispetto a EU4Health, che sicuramente poi approfondiremo con il nostro lavoro che faremo sulla joint action, ma qualche informazione in più sui finanziamenti nell'ambito di EU4Health rispetto a queste iniziative collegate ci sarebbero utili. Quindi ti chiedo, intanto vabbè,
Salve.
vedo che ti sei appuntato queste cose e coinvolgerei in questa discussione i colleghi delle regioni che ho citato prima. Vabbè, in
Chiedo,
primis
chiedo scusa,
abbiamo... Scusate, c'è un microfono acceso.
sì, chiedo scusa, io non riesco a scrivere la domanda in chat, posso dirla così a lei e la passa al dottore?
Sì, allora
Eh,
la dica in questo momento e poi
s-
passiamo la parola.
sì, volevo chiedere al dottore come influisce, cioè come è possibile raggiungere la vera interoperabilità laddove ci si trova dinanzi a 21 sistemi sanitari completamente differenziati e differenti anche nella gestione dei dati. Quindi questo sì a livello in Italia, però chiaramente compromette proprio la vera interoperabilità anche da un punto di vista di tutela e gestione dei dati ai fini del GDPR. Grazie, Scariati.
Grazie a lei.
Grazie.
Immaginiamo che quando parla di 21 sistemi sanitari diversi si riferisca alle 21 regioni, quindi
Certo,
giusto per
certo.
specificarlo per il relatore che
Certo,
magari lo sa,
certo,
ma
perché poi a livello regionale influisce anche una gestione regolatoria e legislativa, no? Per cui tutto
certo,
questo interagisce con la tutela del dato e il raggiungimento dell'interoperabilità ai fini dell'utilizzo dei dati.
certo, ok,
Grazie.
molto chiara la domanda, grazie mille. Allora,
Lisa,
immagino che...
scusa
Prego.
l'interruzione, credo che il relatore abbia avuto qualche problema tecnico con l'audio dell'app. Adesso riesci a sentirci? Solo un double check se ha sentito tutte le domande.
Licinio, hai sentito tutte le domande?
Only now, only 1 minute ago, I started to hear the translation. I'm very sorry for that.
Don't worry. Don't worry. Ok, procediamo intanto in questa direzione, poi facciamo un passo indietro se vediamo che ci siamo persi i pezzi. Allora, invito al dialogo le regioni Lombardia con Alessandro Amorosi, poi abbiamo Friuli Venezia Giulia, Paola De Mario, abbiamo Maddalena Illario, Regione Campania, Liana Spazzafumo Marche, Sara Testa, Provincia Autonoma di Trento, Fondazione Bruno Kessler. Quindi ecco, se magari vi volete anche palesare con il video, così almeno ci vediamo in faccia.
Buongiorno.
Buongiorno, buongiorno, ben arrivati. Allora, io intanto lascerei la parola a Licinio di nuovo se vuole darci riscontro rispetto alle prime cose che ho chiesto io e poi un po' alla volta vi chiedo di intervenire tranquillamente, siamo in 5 o 6 a parlare quindi non dovremo crearci problemi, quindi tranquillamente intervenite quando volete, do la parola a Licinio se ci può intanto rispondere alle prime cose di cui ho fatto io degli appunti, grazie.
I would love, but unfortunately, I didn't. So maybe the other participants can start and I will answer at the end.
Ok, good. Ok, allora la parola iniziamo da Alessandro Morosi, Regione Lombardia, che vedo connesso, da Maddalena Illario, insomma, prendetevi la parola quando volete, cominciamo da queste domande e poi torniamo indietro sulle mie.
Grazie Elisa. Parlo in italiano. Lucina, are you okay? I speak in Italian. Can you hear? I guess so. Well, parlerò in italiano.
Sì, parla in italiano Alessandro, ok, ci sente, avevo l'impressione che si fosse
Ok.
fermata l'immagine. Vai Alessandro, grazie.
Ok, no, grazie per il contributo che è stato molto chiaro e ci ha permesso di capire le attività del progetto nella sua dimensione più ampia. Ovviamente noi partecipiamo del progetto anche in parte direttamente, per cui sono un po' a conoscenza delle attività. Devo dire che grazie alla presentazione l'ho capito un pochino ancora di più, perché nonostante questo è molto complesso il quadro del CEF e IHDSI nella sua complessità. Come domanda specifica scenderei direttamente nella realtà, nel senso che abbiamo avuto un'accelerazione nel tema dell'interoperabilità perché siamo stati coinvolti direttamente nella Green Card per l'utilizzo dei vaccini e per quindi il trasferimento delle informazioni sulla proof of vaccination dei cittadini italiani e mi chiedevo se tanto per cominciare, quanto lo spazio, quanto il progetto di cui ci ha parlato Licinio è coinvolto sulla Green Card europea e se ha idea già di quale sarà l'utilizzo secondario di questi dati, a parte il diretto impatto ovviamente sulla possibilità per i cittadini di trasferirsi e accedere agli altri paesi di Europa.
Thank you very much for the question. And thank you for the feedback on the presentation. The straight answer to the digital green card being part or not of the European health data space is simple. At this point, there are so many doubts on the societal issues that the digital green card can do that adding a layer of secondary use to that information will make it even more complex. So in terms of purpose of use of the digital green certificates, we are trying them to be exclusively for opening the borders, increase the mobility between countries, but not exploring the secondary use of health data.
Okay, so maybe I can ask a few questions. Hi, Licinio. It has been a pleasure hearing about your database, data space in Europe. And I would like to ask whether there is a consideration for data deriving from social systems, because our challenge here on the ground is to integrate social and health services horizontally. And social data often are not standardized as much as purely health data. So I was wondering whether there will be an effort foreseen in the creation of the data space, also in terms of research, to facilitate the exploitation of data from the social systems. This was the first question.
Did I answer to your question?
Non capisco cosa succede. Maddalena?
Lisa, io pensavo di aver fatto una domanda, ma non credo che mi stia sentendo. Io posso ripeterla in inglese se volete.
Sì, l'hai detta in inglese.
Ah,
L'hai detta in inglese, Maddalena.
scusate, la dico in italiano, non me ne...
Allora, se puoi ripetere in italiano,
Sì,
se no qua oggi con
allora,
la traduzione facciamo un
scusate,
caos
sì, hai
pazzesco.
ragione, scusatemi, non me ne sono neanche resa conto. Allora, la domanda è l'importanza dei dati che derivano dai sistemi sociali sulla salute è fondamentale anche in relazione al riferimento alle patologie rare che è stato fatto, perché spesso i dati raccolti dai sistemi sociali influenzano gli approcci integrati di salute e servizi sociosanitari. Quindi mi domandavo se all'interno del data space europeo ci fosse prevista l'integrazione anche di uno spazio anche per questi dati, se in coerenza con questo sforzo ci fosse anche una previsione di una ricerca orientata in questo senso, perché spesso i dati sociali non sono strutturati come i dati standardizzati, come i dati che noi usiamo nell'ambito sanitario, clinico e quant'altro. Quindi volevo capire se c'è un orientamento anche in questo senso oppure se è una cosa che verrà affrontata dopo.
Sono la Regione Marche, posso fare un intervento? Mi sentite?
Aspettiamo che Licinio risponda prima a questa domanda, così cerchiamo di andare ordinati. Grazie mille, Liana, un attimo solo. Prego, Licinio.
It's very clear that only a very small set of research studies try to combine data from different sectors. And even some countries organize health and social under the same ministry. But that's not the case for all. So these are two different ministries in most of health countries, in most of member states. So the principle of having the European data space, the idea of, you see, the idea of these data spaces for health, social, environment, that somehow they share a common platform of governance and interoperability standards is exactly to deal with that challenge that is very particular of healthcare, that in healthcare we need data. If you want to understand data and extract conclusions from it, findings from it, you may need to join with agriculture, social, professional, and also from the environment point of view. That's a challenge, but that's the goal. So make that a possibility.
Grazie Licinio, la domanda era perché nella tua slide mancava il box social, quindi immagino fosse contenuto all'interno di health?
Ok, grazie mille. Adesso Liana, prego, Regione Marche.
Sì, io avevo una domanda un po' legata ai dati, perché effettivamente si lega un po' a quello che diceva la collega Ilario, quello dell'interoperabilità, perché effettivamente i sistemi nazionali sono diversi, i dati sono organizzati in un modo diverso, ho visto dalle slide che si prevede comunque una standardizzazione, però mi domando se effettivamente tutto questo è stato modellizzato, è stato previsto, se questo poi permette sia di avere uno standard a livello europeo nello scambio di questi dati e sia anche una buona qualità, soprattutto considerando che ci sono normative diverse, anche se abbiamo un riferimento che è quello del GDPR europeo, però di fatto ci sono delle normative nazionali che potrebbero essere più restrittive rispetto a quelle europee, e poi l'idea è quella di connettere e di condividere dati che provengono da settori completamente diversi e quindi come poter armonizzare tutto questo sistema. Se ci sono dei modelli di sperimentazione, se è previsto anche un modello di sperimentazione di dati che provengono anche da settori della ricerca oppure dalle biobanche. Insomma, queste erano un pochino le nostre perplessità, domande rispetto a questo bellissimo progetto, insomma, di condivisione e di utilizzo di dati sulla salute in più settori a livello europeo.
It's so good to hear that there are so many people thinking in the similar direction. At this point, and I'm trying to be very concrete, but you know, in the beginning of a journey, you need to use principles because that's what we have, principles. And we have these two principles, diversity in one hand and harmonization in the other hand. We know that that from everything that the stakeholders are telling us, we cannot tell to each country, all of you need to work in this unified way and change everything you've been doing in healthcare in the last 30, 40 years. It's disruptive, and we don't have that power as European Union, in particular in healthcare. We don't have competence inside of the country. So the countries are free to go there. So we need to build a different framework that is not demanding, that is not obliging. It's creating the baselines that the member states can put in place if they want to achieve a common goal. So the European health data space is the common goal. The nodes are the tools for the member state. The nodes that we saw in the pilot are the tools for the European health data space. And when you establish a node, you are saying that that node will communicate with other nodes in a standardized way. And that node has the responsibility to ensure that under his jurisdiction, data holders and data consumers behave according to the rules that have been established at international level, at European level. So we are trying to create this construct where you give the power to regulate inside the country is to the country, but we create a common way of a common vision for the European health data space. And that goes for governance, for semantic interoperability, and for technical interoperability. So at this point, we don't have a common standard on how things will be done, but there is one strong principle: federated querying and data analysis. Data stays where it is. The research questions go to the data. We are looking to standards that allow us to build on this principle. Was it answering to your question somehow?
Posso intervenire sempre su questo tema che mi è caro, quello della privacy? Volevo capire appunto, io la vedo una sfida veramente grandiosa, proprio perché io lavorando in questo ambito quotidianamente ho dei problemi già a gestirmi all'interno della regione sull'interoperabilità fra varie aziende, quindi volevo capire sia nell'ottica della privacy by design, per quello che immagino abbiate già impostato come valutazione di impatto, a livello di gestione della sicurezza dei sistemi così diversi, è comunque si prospetta un rischio accettabile quello nella gestione di questi dati. E poi volevo capire bene come nello specifico si pensava di gestire le diverse titolarità, responsabilità, quindi cotitolarità eventualmente o nomine di volta in volta da fare e da gestire come responsabili, tra virgolette, esterne, insomma, ai sensi del 28. Grazie.
So thank you for this question. So the first step is to create, and I like very much your question because it brings the liability to how we can do things. So that's really great. And the idea of the node is to make sure that inside each country, liability is well known. There needs to be an organization that is liable for what is happening to data from that country when data goes abroad. And that responsibility is to be defined by each country. How we will create this authority, how will we create, and which will be the powers and the roles of such an authority, how to get there. How will this authority be organized, taking into consideration the different regions? But that authority has an important role, is to make sure that whatever data is made available follows the principles, the European principles for GDPR, as well as follow the national acts on protection of privacy and so. So that authority has these two roles: speak with it at the European level, but ensure our national principles and values that we have defined. If someone is requesting us data that we cannot go away, that authority should say, we cannot provide that data at this point. If someone is making available data following, here is all the full data sets with patient level data set, here is everything. That authority should have the scientific committees to define, well, this is not according to our principles adopted, or at European level, or here, this data should not go out of the country in that way. Then it comes in the anonymization and pseudo-anonymization techniques. I think we can all agree, even if this is can be challenged, that real anonymization of data in healthcare is very unlikely. It's most of the time it's always possible to re-identify the person. If we assume there, we need one of the second elements of design is we need to have these common techniques of pseudo-anonymized data to make sure that it's not up to each country to identify which are the practice and which are the standards to pseudo-anonymized data. If this has been agreed at European level that this is the standard, possibly at your level, when you need to say yes or no, this information can circulate, you can have this reference framework that says, has this data been pseudo-anonymized to get to that acceptable level of risk? Those would be my 2 points on that.
Se posso aggiungermi io con una domanda che un po' si collega a quanto detto adesso sul discorso della privacy e sull'impossibilità comunque nell'ambito sanitario di anonimizzare i dati. E qui in Trentino, con il centro di competenza sulla sanità digitale, siamo un po' sia data holder che data consumer, quindi sia la ricerca che l'healthcare trust, insomma, il provider sanitario. E quindi stiamo cercando di trovare una base giuridica che sia conforme al GDPR per l'utilizzo secondario dei dati, e quindi stiamo definendo il patto col cittadino, che è la possibilità per il cittadino, tramite il proprio personal health record, di dare il consenso volta per volta di condividere i propri dati sanitari per specifici progetti di ricerca. Quindi questo è qualcosa che stiamo cercando di fare a livello locale per l'utilizzo secondario dei dati. La mia domanda è nell'ambito sia dello European Health Data Space che però anche nell'ambito del Data Governance Act. Come si configura, per esempio, questa iniziativa? Come si può esportare, scalare a livello europeo? Per esempio, penso al Data Governance Act, il concetto del data altruism, questo può essere collegato in qualche modo o nello European Health Data Space? È possibile per noi appunto portare questa iniziativa locale e renderla un po' più scalabile, magari tramite un nodo come quelli previsti insomma nella slide che ha fatto vedere?
Definitely. Definitely, data altruism is one of the aspects that is being studied. We can even give one step further by saying, what does it mean, data altruism? It doesn't mean that the patient is in power, on hold of all his health data, and he can say, like, I'm being the blood donor of my blood to someone. Can I donate my data to someone else to make studies? And we are looking at how that in practice would be, from the patient holding the data, the patient having his data on a trusted data provider, and from that on provide access to specific authorized consumers to that type of data. So we are seeing different patterns on how making this data altruism approach a reality. For sure, the consent, explicit consent for each type of research is one way, but we must admit that it also, by ensuring that patient is always aware, I'm giving you consent for this, for this, for this, for this, it also creates this difficulty to make research and innovation. So we are also looking at ways, how can this be provided in a different way? How can this be information made available from a national act, a legal basis that allow this information to be used without explicit consent needed? So one consent possibly, and from that on, this information is available under certain conditions. I would like to bring to one point that connects with the previous. You mentioned the pure, let's say, the 100% anonymization of data. We learn that will never be possible because of one fundamental requirement. One of the best outcomes that you can have by reusing data from one patient is to identify findings that can be helpful for that specific patient. So we are starting to hear this called the linkage, the linkage of data to a patient. And if we don't want to lose that possibility that we discover something that we would like to inform the original individual of that data, that he may have something to do in his health, it will never be 100% anonymized. So that's also one of the discussion factors. Yeah.
Io avrei qualche altra domanda. Volevo chiedere se allora l'utilizzo dei dati su questo data space richiederà la collaborazione tra esperti di diverse professionalità, di diversi ambiti, e una delle problematiche rappresenta il riconoscimento da parte dei medici, il coinvolgimento dei medici e delle professionalità sanitarie all'interno di questi gruppi di lavoro dovrebbe essere riconosciuto, perché ciascuno di noi è operato dalla quotidianità delle attività di routine all'interno dell'ospedale ed è difficile riuscire a coinvolgere all'interno di un gruppo che può essere indispensabile per creare delle analisi aggregate che abbiano un valore specifico per un determinato tipo di obiettivo, riconoscere il tempo che deve essere dedicato a queste attività collaborative, a questo tipo di analisi. Quindi mi domandavo se ci sarà un'azione di sensibilizzazione da parte della Commissione europea rispetto ai policy makers e decision maker sulla necessità di coinvolgere all'interno dei teams informatici anche queste professionalità cliniche e mediche che sono poi fondamentali per decidere quali dati si devono aggregare, che tipo di obiettivo si deve collegare ad ogni tipo di analisi. Cioè questo potrebbe anche essere coerente con gli obiettivi di ricerca per uno degli ambiti che sono stati descritti nella presentazione. Gruppi di lavoro internazionali, naturalmente.
I think you touched upon one of the most sensitive topics from the last 10 years in data quality. Let me explain. One of the challenges in the My Health at EU, the project we spoke at the beginning, where the patient has a patient summary that is available when he goes abroad. There was one fundamental question: how is that patient summary, that aggregation of data, created and maintained so that when a health professional in another country asks for it, can be assured that that data is of good quality? And at that point, different strategies emerge because of that, because the time a health professional dedicates to prepare a patient summary was not recognized as a healthcare activity.
Esatto.
So some countries came to this idea of, in order to prepare a patient summary, you need to schedule a consultation with the patient. And that during that consultation, what you will do is prepare the patient summary. But that's not an overarching approach. So obviously, there is no straight answer. And the only thing to the question, will the time spent by health professionals in preparing these research studies be considered as time they have spent providing healthcare? Definitely, we don't have an answer. We were not tackling the regulation from that perspective, but I will take home because we are getting this remark more and more.
Un'altra domanda è, allora, è stata citata da una delle altre colleghe collegate la necessità la sfida dell'interoperabilità. Io mi domandavo se all'interno delle attività di ricerca ci sarà un'attenzione allo sviluppo di ontologie applicate alla salute condivise, perché la conoscenza l'uso delle ontologie condivise non è molto conosciuto e potrebbe essere utile per collegare database frammentati all'interno della dataspace europeo. Quindi però c'è bisogno di investire ancora, perché non abbiamo una familiarità sufficiente con la creazione di queste ontologie e con l'uso di queste ontologie per collegare i dataset. Quindi mi domandavo se ci sarà anche questo tipo di approccio per rispondere in parte alla necessità di interoperabilità.
I believe when I was presenting the framework on legal and organizational data quality, infrastructure, and skills, capacity building, in the data quality, there was this line on verification projects. And our vision at this point is that we can use the EU for Health, that is the big financial program that is coming for the next 7 years, where we can make available grants for organizations to apply. And they say, I want to make my data fair. By fair, meaning findable, accessible, interoperable, and reusable, according to the principles of the European health data space, meaning possible there will be some specific standards, OMOP, HL7 FIRE. It doesn't matter to speak on the standard what it is. What it means is that we recognize that there is tremendous data sources out there, and one of the major challenges is how to make that data available for further use. So we are planning to provide support for that specific term. It's not for new IT, all of those can exist, but that in particular, that money will be to make data available and make it in a reliable, qualitative way.
ultime domande. Potrebbe darci qualche chiarificazione in più sulle orphan data holder? Erano citati in una delle slide. Orphan data holder e anche la dimensione minima del nodo. Quali sono, se già sono state definite le caratteristiche di un nodo?
The answer, the first one, what is an orphan?
Orphan data holder.
An orphan consumer, imagine, I will be provocative. Imagine, so I cannot be provocative because it's recording. So I will imagine a researcher from the United States. So it does not belong to the jurisdiction of an European country. So instead of going to Italy and ask, dear Italy, can I make a research question to the full Europe? He should go to the European Permit Authority that will have the protocols for non-European member states, policymakers, researchers, and regulators, like FDA. FDA wants to make some question. Obviously, it can ask to EMA, and EMA can take care, but if FDA would like to ask that directly, it can go through the European Permit Authority. On the minimum definitions for the nodes, there's nothing in written what a node should be and who should be in the country. But the main functions become very clear. And these are, they belong to this governance body. Together, these nodes belong to this governance body that defines the standards in which data is exchanged between them, the policies to access and provide data, and they are the idea of, and that is challenged especially in countries that have this regional approach, but the idea of the single entry point into the country. So these are the three main functions that have been highlighted as baseline. We can call it minimum requirements, but they do not allow us to identify, oh, so in my country, the best positioned organization is that one or that one. That's something that when the regulation comes, the countries should think and interpret that regulation. Who can be that authority? If it can be only one, or we need to have more than one.
Grazie Licinio. Ci dai ancora 10 minuti? Puoi darci ancora 10 minuti? Perché il tempo sta passando velocemente. Perché abbiamo ricevuto altre domande privatamente nella chat e poi abbiamo anche visto una mano alzata. Quindi vado un attimo in ordine di comparsa, anche quello che voi non vedete. Quindi chiederei a Leopoldo Comisso di fare la sua domanda, Friuli Venezia Giulia.
Buongiorno a tutti, io volevo chiedere riguardo praticamente allo scambio di dati, per quanto riguarda la parte amministrativa, c'è già la piattaforma europea ESI che prevede lo scambio di tutta una serie di informazioni fra le varie istituzioni sanitarie di tutta Europa, sono collegati praticamente tutti gli ospedali e tutte le ASL, le utilizziamo anche per la tariffazione, per i rimborsi ed altro, e quindi è già una piattaforma operativa che prevede già scambio di dati in forma di documenti strutturati, armonizzati, eccetera, se l'esperienza potrebbe essere utile espandendo la interoperabilità anche ad esempio per tutta una serie di scambi di dati di carattere sanitario, come ad esempio continuità delle cure e così via, in particolar modo appunto per le cure cross border oppure per ospiti temporaneamente presenti oppure affiliati a istituzioni di altri paesi. Scusate che non si la videocamera si era spostata, non mi ero accorto. Grazie.
Thank you. Would you be so kind to say it again or write in the chat the name?
No, ESI is for administrative purposes, not for scientific purpose.
ESI, oh yeah, ESI, yeah, ESI is the sister. So ESI is the electronic exchange of social security information. It's the sister platform of the My Health at EU. So they build on similar principles. They are both DSIs, digital service infrastructures, from a program called Connecting Europe Facility. At this point, I confirm that there are no synergies between. We should definitely reconsider the current status.
Ok, grazie. E vedo Raffaella Marconi, una domanda, se vuole porla a tutti, e poi la parola a Marcello Melgara successivamente. Ma prima Raffaella Marconi, sei ancora collegata? Non arriva Raffaella? Diamo la parola a Marcello Melgara. Vai Marcello.
So, you know, should I speak Italian or English? Italian, maybe.
Vai in italiano, così è più semplice
Andiamo in
per tutti gli
italiano,
altri.
allora
Grazie.
parlo piano. Volevo ringraziare Lisinio, ovviamente, perché effettivamente molti temi sono stati portati. Io avevo un commento su una domanda e risposta, ma direi che a questo punto farei un discorso leggermente più ampio. Secondary use of data, sono stati portati veramente molti punti, molti aspetti. La parte legale, la parte di disponibilità dei dati, la parte di coerenza dei dati, e quell'ultima domanda a cui anche Lisinio stava rispondendo, portando l'esempio del patient summary. Noi ci siamo resi conto che anche se utilizziamo lo stesso CDA, utilizziamo gli stessi code system, i modi, i significati trasferiti da una nazione o rispetto ad un'altra nazione sono completamente diversi. Un esempio stupido: alcuni portano i dati recenti, altri dati significativi. Capite che anche fare delle analisi statistiche su due insiemi di dati così diversi è molto difficile. All'inizio eravamo dei puristi, volevamo avere tutto codificato. Adesso ci stiamo rendendo conto che non possiamo fare dei mapping da un code system all'altra, quindi stiamo iniziando a lavorare su cose che sono preferred code system e, come Lisinio sa, stiamo cercando di introdurre un concetto di avere un underlined coding system con una ontology, e questo underlined può essere un ICD-11, può essere uno SNOMED con le sue ontologie, quindi non dobbiamo definire delle nuove ontologie. Abbiamo da decenni vari enti di standardizzazione che stanno lavorando. SNOMED ce l'ha fatta, non tutte le nazioni possono utilizzarlo. Quello che si cercherà di fare è avere comunque un collegamento semantico alla ontologia SNOMED, anche se noi come Italia e come tante altre nazioni non lo potremo utilizzare, perché è impossibile mappare dal nostro ICD-9-CM ad UDCD-10 in un modo o nell'altro, e poi in ogni caso le regole di codifica si basano su delle linee guida regionali, addirittura nel nostro caso, o nazionali. Quindi effettivamente tutte le cose che Lisinio ha descritto per il secondary use of data confliggono con la finalità del trattamento con cui sono stati raccolti, con la omogeneità di modalità di creazione di questi dati, con l'impossibilità di effettuare dei mapping. E qui adesso Lisinio ride perché abbiamo tirato fuori da un po' di tempo, lui ed io, il concetto di interoperability of minds, seamless interoperability of mind. Questo è il nostro obiettivo: fare in modo che medici e ricercatori capiscano esattamente le stesse cose quando analizzano dati provenienti da sorgenti diversi. E un grande grazie a Lisinio e a voi che avete organizzato.
Grazie Marcello, grazie anche a te che ci hai permesso anche di connetterci con Lisinio, e quindi insomma questa è stata un'ottima opportunità. Lisinio, se concordi, io proverei a ripeterti un po' quello che ti dicevo all'inizio della sessione delle domande, che erano più da parte mia, ok? cercherò di essere molto breve, nel senso che mi hanno colpito molto le iniziative che avete appena avviato, state per avviare, inclusi i pilot, e quindi probabilmente ciascuno di quelle ricerche pretende un approfondimento che magari potremo fare più avanti insieme e probabilmente dedicare proprio un webinar per ciascuna tematica, perché sono cose molto ampie, molto interessanti e crediamo che una ricaduta a livello nazionale di regioni sia fondamentale di tutte le iniziative, perché così vengono veramente recepite. Quindi ti disturberemo su questo, quindi questa era solo una affermazione che volevo fare, ma tu dicevi anche che era possibile partecipare in qualche modo. Noi sappiamo che e quindi contribuire a questi studi che state per attivare o avete già attivato. Noi sappiamo che voi lavorate in stretta connessione con il Ministero della Salute sicuramente e anche con alcune regioni, non da ultima Regione Lombardia, ma se magari nei prossimi giorni o ora ci puoi dire anche come Promise eventualmente può contribuire coinvolgendo anche altre regioni, per noi sarebbe davvero importante perché è proprio la nostra mission è quella di creare collegamenti con le diverse iniziative. La seconda cosa che ti chiedevo era quali connessioni, cioè sicuramente siete connessi anche con DigiConnect, scusatemi il gioco di parole, e rispetto proprio al programma Digital Europe e quindi a tutto il tema del Digital Innovation Hub, vorremmo capire come le iniziative in qualche modo si connettono e noi partecipiamo a una rete europea informale dei Digital Innovation Hub, quelli selezionati proprio dalla Commissione per partecipare al programma Digital Europe. Stiamo cercando di contribuire dal lato salute per far incrociare domanda e offerta e quindi ci sarebbe anche utile capire come DigiConnect e DigiSante stanno collaborando in questo tema che è ampio. Sicuramente sono due aspetti paralleli ma che a un certo punto dovranno incontrarsi e incrociarsi in qualche modo. E poi direi l'ultima cosa, altrimenti non finiamo più. Sì, ci interessava sapere un po' di più sui finanziamenti di EU4Health. Dicevo che come Promise a fianco al Ministero lavoreremo per l'implementazione proprio di EU4Health a livello nazionale nella joint action che di recente è stata finanziata e avremo proprio il ruolo rispetto al tema della capacity building del National Focal Point del programma Salute Pubblica, ma anche proprio sul tema della sostenibilità del programma. Quindi insomma saremo attori attivi in questa cosa, quindi saremo molto collegati con voi e vorremmo, se già ci puoi dire qualcosa, già qualcosa hai accennato prima rispetto a che tipo di iniziative potranno essere finanziate, ma se ci puoi dire qualcosa di più. Ho finito, nel senso grazie.
Pleasure. Listen, let me try to see if I can provide answers, meaningful answers to most of those. Starting with the EU for Health, what is the administrative step that is missing? So the program, EU for Health, is a funding program. And that funding program is now under this administrative decision that is expected to come out before the end of June. After the end of June, meaning when this administrative decision is coming out, we can start launching the calls for anyone that would like to apply on that. And we believe that our aim is before the end of the year, establish the first grants, assigning the first amount of money to allow the players to start working and help us in the European health data space region. EU for Health is bigger, but in this particular scope, this is the timeline we have. And indeed, we spoke about verification projects, we spoke about nodes and capacity building. These are examples of the nature of projects that we, from the European health data space, we expect this to be available for you to apply. So these three: verification, working on quality of data; infrastructure, be part, connecting your hospitals to this European health data space; and also in skills, promoting any kind of increasing, upskilling people and patient literacy, citizen literacy. So this is for EU for Health, where we are at this point. So no much more I cannot share much more. On connecting with Connect, nice one. And the other funding programs, we have two major ones: the DEP, Digital Europe Program, and we have the RRF, the Recovery and Resilience Facility. So these three programs have different approach. The RRF is a funding program that is up to the country to say strategically, this is where we want to invest to increase the resilience and to recover our country, in particular in terms of healthcare system. So this is something that we have been talking to each country, the ministries, and asking them, what are your plans? What are you expecting to do regarding interoperability of healthcare? What are you expected to do regarding secondary use of health data? So we are making these questions. So in case countries have not thought about it, include those type of things that we believe are important for the European health data space, so that the countries could include it in the RRF. So this is strategic, structural. The EU for Health is specific for health and to deploy things. It's a deployment project. The DEP it's not the research innovation, but it's still exploring and allowed to scale up some solutions. So, but it's very driven from a technological point of view and not from a sectorial point of view. So what we did is we extracted the health part from what was previously the CEF, that is so now it's DEP, and it was CEF before. And we extracted the health part and we put the health part in the EU for Health. So what you see in the digital health program is what they call generic building blocks. They are not sector specific. They are like artificial intelligence. They are like high processing computer. So things that can be applied for different sectors. So that's the relation with Connect, at least at funding level. There are more relation because the Digital Governance Act, it's coming from Connect, and the European Health Data Space Regulation will come from Santé. So we know that this one, the second one, is a specialization of the provisions on the Data Governance Act. So we are in full alignment with Connect and with all the other DGs that are representing the other sectors. So that's very important to us, not just in point of governance, but also in point of standardization, selection, and ensuring the interoperability across sectors. How can we involve more the regions and the citizens in the process of designing the European health data space? You spoke, and I'm very glad you mentioned it. There is the joint action to support the European health data space, and this is already started a couple of months ago, and this includes partners from that applied from national side. It was not only the Ministry of Health. There are several regional partners participating there, and that's one of the main channels we have to get options. But the main one we would like now to do is the citizens consultation. We really want to put forward, and that's our biggest initiative for the Q2 and Q3, is to hear what citizens have to say on the European health data space for primary and secondary use of data. And that should happen in these 6 months we have from now to ahead of us. And in the studies that we are doing, infrastructure, regulatory gap analysis, we are challenging the organizations that are making the studies for us to consult a wider range of stakeholders. So we always try to give them freedom to select, and we say we need policymakers, we need researchers, we need companies, we need health professionals, so that they bring to us a methodology that says this is how we can get to as many, so that the conclusions of the study are somehow representative of the different stakeholders. So concretely, participate in the studies. You know that these studies are happening. If there is a request for participating as stakeholder, going to a workshop or answering to a survey, this is the right way. Be aware that the citizen consultation for the European Health Data Space will exist, and the regions should empower and should be aware of that. And obviously participating in the joint action for the European Health Data Space, because they will do stakeholders consultation. They are a small group of 20 or 25 organizations, but they know that they want to hear in particular policymakers, so they want to get that. So they will organize those workshops. And the pilot, at this point, it's still closed to very specific organizations. I could speak a little bit more on pilot, but I don't think the pilot is a general engagement tool at this point. I hope I answered the question somehow.
Ok, tutto molto chiaro, grazie mille anche per queste ultime indicazioni che ci sono molto utili, e magari torneremo ogni tanto a disturbarti anche via email per chiederti eventuali specifiche, questo per noi è molto importante. Bene, allora io credo che abbiamo finito e non vedo altre domande, soprattutto è anche molto tardi. Quindi Licinio ti ringraziamo tantissimo e come detto torneremo sicuramente a disturbarti sia per eventuali altre informative generali fatte alle nostre regioni, ma anche poi magari specificatamente in un dialogo con Promis diretto per avere qualche scambio. Grazie ancora, grazie a tutti i partecipanti, grazie a Regione Lombardia che ci ha anche permesso di avere questo contatto diretto. Grazie ancora, grazie alle regioni, arrivederci a tutti.
Giornata, grazie.
Grazie mille,
Voi,
arrivederci.
grazie.
Thank you very much for having me.